that. And all right, so welcome everybody to our Wednesday morning grand rounds. And for our introduction of our speaker today, I'll turn it over to Dr. Bergen.
Terrific. Well, welcome everybody. And it's a great pleasure for me to introduce Ashraf El Naga. Ashraf's in his second year of clinical practice with us here at UCSF. And Ashraf comes to us from Topanga, California, down in Southern California. He was an undergraduate at UCLA. He studied chemical engineering there, went on to UCSF for his medical school, and he actually did research in Dr. Lotz's lab between his third and fourth year of medical school. He went on to the Baylor College of Medicine, where he did his residency and really saw a lot of trauma there, and came back to UCSF as a trauma fellow here at SFGH. He then did a spine fellowship after his trauma fellowship up at Harborview in Seattle. And we were fortunate to be able to recruit Ashraf back to join our faculty now nearly 2 years ago. Ashraf's academic focus is on spine trauma, as well as looking at clinical outcomes of trauma. And Ashraf's going to give us today a spine surgeon's perspective on surgeries that involve the spinopelvic junction. So thank you, Ashraf.
Yeah, no, thank you so much. Is the correct screen showing up for you? Okay.
Yeah, that's good.
Looks great.
All right, yeah, well, Dr. Bergman, thank you so much for the kind introduction and the opportunity to speak at our department's grand rounds. So I'll be discussing the treatment of injuries at the spinopelvic junction. Admittedly, this is not going to be as widely relevant to everyone's practice as Dr. Kim's great talk last week on how to optimize our time in clinic with patients, but I hope that there will be some parallels between what's presented in the particular practices, and especially to those who are working at the intersection of two subspecialties. So in preparing for this talk, I chose a topic that reflects the overlap and background in both spine and orthopedic trauma. And the spinopelvic junction is literally at the intersection of these two. So here we go. So there's no relevant disclosures for this discussion. Our objectives are as follows. So I'll review the most recent impactful studies related to spinopelvic injuries over the past couple of years. And in doing so, highlight some of my own research interests and questions as it relates to these. We'll discuss the rationale behind the newest classification system for these sacral injuries. And finally, our last goal is to discuss the clinical factors that guide our treatment choices for these widely varied but occasionally very devastating injuries. So to achieve these, we'll first discuss the relevant anatomy, including biomechanical considerations and common injury patterns, and the advent of the new sacral fracture classification system that was a joint effort between AO Spine and AO Trauma. And then we'll discuss the surgical treatment for these varied injuries and round out with some case examples. So the spinal pelvic junction. So despite its crucial biomechanical and neuroprotective roles, the roles of the sacrum and the spinal pelvic junction, injuries to this area in the past have largely been overlooked by the realm of spine trauma. Reasons for this are multifactorial. They include the historical difficulty with imaging this area, shortcomings of historical fixation techniques such as sacral plating, and an array of previous overlapping classification schemes, as well as the paucity of literature regarding these highly variable, potentially devastating injuries, such as displaced transverse sacral fractures, such as the one pictured here, only accounting for less than 4% of all sacral fractures. So I know we're jumping ahead, but bear with me. So while many sacral injuries are stable and can be treated non-operatively, unstable injuries are considerably treated by one of two techniques. Iliosacral screws describe the placement of an entirely intraosseous screw across the ilium to the sacroiliac joint and across the sacral fracture, thereby stabilizing it. There are different trajectories that we can use based on the specific injury we're trying to stabilize. But for the fractures that we'll be talking about today, this transiliac transsacral corridor is what I'll be referring to. This is a percutaneous procedure, minimally invasive and well tolerated. On the right is a different approach, lumbopelvic fixation, where screws are secured proximally into the lumbar spine and then into the pelvis, and these screws are connected with a rod to bridge across. Though clearly more invasive, this can be done via both open or percutaneous techniques, but both are more invasive than iliosacral screw fixation. In patients with nerve root compression, either of these techniques may be combined with a decompression for the compressed nerve roots. So let's first, talk about sacral anatomy before delving into these two techniques and when one may be beneficial over the other. An understanding of the anatomic relation of the sacrum to the lumbar spine, pelvis, and surrounding neurovascular structures is critical in evaluating the functional deficits that we would expect when someone presents with a sacral fracture. The sacrum is the junction between the spinal column and the posterior pelvic ring. Its stability is based on well-developed ligamentous connections as well as an intricate osseous architecture. When these ligaments are intact, particularly the sacroiliac ligaments, and the symphysis, the pelvis can resist external rotation and flexion of the hemipelvis with load bearing. Simplistically, we can think of the sacrum as a keystone that allows transmission of load between the bilateral lower extremities and the spine, and allows for supporting the lumbar spine and everything cranial. Much in the same way that a keystone in a Roman arch allows that arch to support an overlying load and transmit its load to those two limbs. This load transfer occurs via the sacroiliac joints, which extend between S1 and S3. A few statements about nerve roots. So the L5 nerve root exits from the L5-S1 neural foramen and transverses just anterior to the sacroiliac bilateral. These nerve roots can be injured as the result of displacement at the time of injury or by errant screw placement anterior to the sacrum. Foraminal nerve root injuries are more likely with the upper sacral nerve roots at S1 and S2, as in these foramen, the nerves occupy a greater proportion of the foramen as compared to the lower nerve roots. And it's generally thought that bilateral injury to the lower sacral nerve roots is thought to be required for the loss of voluntary bowel and bladder control. So despite being a funny shaped bone, there are several corridors of bone in the pelvis where we can safely place screws to secure the bone. The red boxes here are the mainstay of posterior pelvic ring fixation. There's this transverse corridor outlined with the yellow box in either the upper or second sacral segments. And then there's the sacral buttress corridor, the red box outlined in red, which sort of spans the area between the posterior superior iliac spine posteriorly and the anterior inferior iliac spine anteriorly. So safe screw placement requires an understanding of patient-to-patient differences and frequent anatomic variations, bringing us to the concept of nondysmorphic versus dysmorphic sacrums. In the nondysmorphic sacrum, a transverse screw can be safely placed across the upper sacral segment all the way from one ilium across the sacrum into the other ilium on the other side. In the dysmorphic pelvis, however, the sacral body is translated a little bit more anterior, and a transverse screw cannot be placed all the way across, and attempting to do so would injure the L5 nerve roots, which again drape over the sacrum as represented by these blue circles here. The last point regarding anatomy I wish to make is that the sacral ila here in the red ovals, these are areas that are lateral to the foramen and they have much lower bone density as represented by this blue color here. And if there's a choice, there's a preference towards fixation techniques that engage higher density bone regions in red and yellow, that are sort of outlined with these sort of purple circles here. So namely the superior sacral end plate, the sacroiliac joints, and the iliac cortices. So to summarize the key anatomic considerations, the sacrum acts as a keystone of the posterior pelvic ring. It allows us to maintain stability while transmitting forces between the spine and the bilateral lower extremities. And we need to understand the neurovascular structures. There are patient-to-patient differences in osseous anatomy that may limit our fixation options, and that bony purchase plays into decision-making. So now on to the injuries that we see. So fractures and fracture dislocations of the junction can include injuries that extend caudally from the L5 vertebra, disruptions to the lumbosacral facets, and thereby the articulation between the pelvis and the spine, and sacral fractures, which frequently occur in conjunction with pelvic ring injuries. So these injuries range from low energy incomplete sacral fractures as seen here with the teal arrow, insufficiency fractures that can only be diagnosed on MRI in the setting of metabolic bone disease, osteoporosis, or minimal trauma, to complex, multiplanar, highly unstable injuries seen with high energy mechanisms. So in discussing these sacral fractures historically, we've come at these from the perspective of the pelvis. And the two classifications that we contemporarily use are the Young-Burgess classification, as well as which, and the Young-Burgess provides more of a mechanistic description of common pelvic ring injuries, as well as the Tau classification, which focuses on pelvic ring stability. And while incredibly informative in describing fracture patterns and direction of hemipelvis displacement, neither one of these relate ring stability to the ability to support the spine or cranially. So the young Burgess describes injuries based on the assumed vector of impact based on residual displacement at the time of imaging, with lateral compression injuries in yellow implying hemipelvis internal rotation. Anterior posterior injuries are in green and represent external rotation injuries. The injuries in blue have a vertical shear component with cranial translation of the hemipelvis. The Tau classification describes injuries based on whether or not the affected hemipelvis is stable in rotationally or vertically. Clearly there's overlap between these two, but neither one of these really captures the essence of lumbopelvic stability. And so we'll sort of turn to the systems that we've used to outline these sacral injuries. Each of these had a different outcome in mind, and while incredibly useful, they're not comprehensive. So we'll begin with the Dennis classification. So the goal of the Dennis classification was to classify, was to describe rates of neurologic injuries based on the sacral fracture pattern. Sacrum is divided into 3 zones, with the foramen being the delineation. And it's based on the medial most extent of the fracture. And so zone 1 injuries are those that are lateral to the foramen. These have a low neurologic injury rate. The injuries in this area are usually just L5 nerve injuries because that's where the L5 nerve runs after it's left the spine. Zone 2s are injuries that extend through the foramen, and zone 3s are the ones that extend medial to the foramen into the sacral canal. These are the numbers that Dennis reported in terms of his nerve root injury rates. Contemporary studies show a much lower incidence of injuries, but the relationship between zone 1, zone 2, and zone 3 is the same. The issue here is that the zone 3 injuries encompass both the vertical fractures as well as those that have a transverse component. As is intuitive, these transverse ones are the ones that cut across the sacral canal and carry a very high neurologic injury rates. And if we parse out the vertical ones, if you look at only the vertical ones, the neurologic injury is surprisingly low, on the order of 1%, less than the zone 1 injuries. So, if we were to sort of organize how we think of these zones in terms of neurologic injury, the vertical zone 3 fractures have a lower neurologic injury rate as compared to zone 1, then zone 2, and then the zone 3 transverse fractures. So while this Dennis classification, while this Dennis classification does well in predicting neurologic injury, one shortcoming is that it fails to take into account injury displacement or lumbosacral stability, which is what Isler tried to do in his 1990 article in classification schemes. So he differentiated a vertical sacral fracture based on whether their cranial extent exits medial or lateral to the superior facet of S1, and fractures that extend medially to S1 were postulated to result in lumbosacral stability. But if we look at his original paper, he describes these as really, these are just postulated outcomes for these injuries, which makes sense. But there's no study that I'm aware of that has looked at long-term outcome and the need for reoperation after these injuries. What's fascinating to me is like this thought, despite the absence of subsequent literature, has also made its way into like our newest classification systems. And so while the Dennis and Isler classification systems do well in describing vertically oriented sacral fractures, there are 2 main ways that we describe transverse zone 3 injuries. The first is an informal descriptive classification, which refers to these fractures with a transverse component according to how the fractures look. So on the top left, the fracture looks like an H, so we call it an H pattern. The U type on the top right looks like a U. In this particular pattern, the U types, the rest of the pelvis is a single unit, which is certainly not the case in an H-type fracture. And this has implications for our fixations for these injuries. And then the other 2 is the lambdas and the T's are based on the direction of the distal fracture extent. Roy Camille further classified these transverse injuries based on sagittal translation and kyphosis. Sacral kyphosis is the most common deformity that we see with these displaced transverse injuries and guides our goals for fracture reduction. And so while with sacral fracture displacement, the traversing nerve roots in the sacral canal are often compressed, as you see in the CT cut, where there's little space for the traversing nerve roots in the canal. And this sacral kyphosis or angulation is the most common deformity that we see with these displaced injuries. If left untreated, this will result in a change to pelvic incidence, and a greater slope seen in here at the lumbosacral junction with regards to the hip. That means that if left untreated, in order to balance this deformity, the lumbar spine will have to hyperextend by the same amount in order to make up for this deformity. So reduction to the sacrum and lumbar spine, the goal is to restore native pelvic incidence. Malreduction leads to increased sacral kyphosis, which can lead to chronic low back pain and muscular imbalances at the spinal pelvic junction. While global, there are studies that have linked global sagittal alignment after these injuries to pain and disability scores, there are no widely accepted values as to what represents an acceptable residual sacral kyphosis. We don't know what our reduction goal should be or have a criteria when we compare one reduction technique to another operative technique. And so we'll come back to our classification schemes. And so while the ones I've discussed have overall led to a better understanding of sacral and spinal pelvic injuries, each of these injuries is either too broad, specific, or simplistic to comprehensively describe the full spectrum of these injuries and to serve as a general guide for treatment. And as such, the AO Spine Sacral Classification System was developed. This was a joint effort between AO Spine and AO Trauma to create a hierarchical classification system. They stick to the general AO principle format of dividing injuries into A, B, and C types, with these A types representing more stable injuries than the C types. And these really tackle the spine fractures from the spine's perspective. So while at first glance, this seems overwhelming, which drives many people away from utilizing this, it's actually a bit more intuitive with the background that we've already discussed. So we'll start off with the A-type injuries. These are lower sacrococcygeal injuries below the level of these SI joints with no impact on pelvis, on spinal pelvic stability, because again, these are below the sacroiliac joint. So A1 injuries, these are coccygeal or ligamentous avulsion fractures. Again, the spine doesn't care about this. That being said, I would caution, especially with the first one here, the first one here may represent an avulsion of the sacrotuberous and sacrospinous ligaments, which can be seen, albeit infrequently, with ABC type pelvic injuries. But again, while the pelvis may care, the spine really doesn't. The A2 and A3 fractures are transverse fractures below the level of the SI joints. And with the 2s being non-displaced and the 3s being displaced. Again, being below the SI joints means that the transmission of load from the hips to the spine is not hampered and the spine couldn't be bothered. Next are our B-type injuries, which are vertically oriented sacral fractures. These are essentially our dentist classification, but reordered in terms of increasing neurologic injury. The mainstay of these treatments is posterior sacroiliac screw fixation with screws holding compression across the fracture site. The C types are any injury that imparts any instability between the spine and the pelvis. And so first are the non-displaced U's. Having these as the non-displaced ones as a separate one is really a push from our European colleagues, especially in light of sort of these, the higher incidence of fragility fractures that we're seeing with our aging population. Because these are non-displaced, there's no reduction needed. If we need to instrument them, they could be potentially instrumented with iliosacral screws, depending on whether the corridors are large enough to allow for screw placement. With the screws shish kebabbing or skewering the proximal segment, the top one, we can place multiple screws across the first sacral segment, and then the lower one with a more distal transverse component, we can put screws across both the first and second sacral segment. It should make sense why an S2 screw would not be of any use in the first on the top image, as this would not cross any fracture line. The C1 injuries are the vertical ones that result in a disruption to the L5 S1 articulation. These are our Isler variants. How the best factor these into treatments is still up in the air. For me, this strongly pushes me towards considering a fusion at this level. And even though we don't have well-described outcomes, this is one of the goals that we're hoping to change in the next couple of years. The C2s are bilateral vertical injuries. These are bilateral type B injuries. In this case, the spine is not connected to either hip, and the bone has no bony connection to the bilateral lower extremities. And then these are the C's. These are the ones that we think of when we think of lumbopelvic instability or dissociations. These are namely the displaced sacral fractures that have a transverse component. And because there are many injury patterns, we just group these all together. These typically require lumbopelvic fixation to control sacral sagittal plane alignment. So we'll move on to treatment. So the goals of treatment are namely the following. So bony union of the fracture site and physiologic alignment. We have the goal of optimizing the potential of recovery in patients with neurologic deficits, and we'd like to minimize complications associated with prolonged recumbency and bed rest. So really getting to our general philosophy of early mobility and weight bearing. As such, non-operative treatment is most likely considered in patients with stable injuries, with intact neurologic functions and minimal displacement or angulation without a major ligamentous injury. A reliable indicator of the adequacy of this treatment is the absence of functionally limiting pain or lumbosacral pain with mobilization. For these patients, there are variations in weight-bearing protocols across practitioners and practices, but in general, it's common to see, to have touchdown weight-bearing restrictions in the young to reduce the risk of displacement, and weight bearing is tolerated in the old, much akin to our philosophies and goal of early mobilization after, say, hip fractures. That being said, because surgical treatment for these non-minimally displaced fractures is safe, we will consider percutaneous fixation if a patient has persistent functionally limiting pain that precludes early mobilization. And this is supported by the literature that shows that percutaneous screw fixation can be effective in decreasing pain and improving return to early ambulation in those who fail the trial of early mobilization. In terms of our operative choices, for patients who meet our operative indications, there are two contemporary instrumentation techniques, the iliosacral screw and the posterior lumbopelvic fixation. In terms of the iliosacral screws, these are safe with proper planning and execution. They can be done through like a 1.5 centimeter stab incision. The patient can be in any position, either prone or supine. And the fracture orientation is usually such that the screw comes in roughly perpendicular to it. And because the screw is roughly perpendicular to it, we can get compression across the fracture site, choosing either lag by design with a partially threaded screw or lag by technique, which is my personal preference. We all go to AO Basic and we learn about lag screws. And from this course, we know that in most areas of the body, whenever we use a lag screw, we typically neutralize it so as to prevent any rotation or shear about the screw at the fracture site. And this is sort of the downside of iliosacral screws. So alone, they are bad at resisting shear forces, and as such, with weight bearing, after standalone SI screw contexts, it's occasionally, we occasionally limit weight bearing if the patient can tolerate it. So that's one issue. Further, these are floor intensive procedures, which may be difficult in the setting of bowel gas or obesity to safely visualize the sacral foramen, though navigation can be used in these scenarios. So compared to iliosacral screws, lumbopelvic fixation is significantly better able to resist shear forces as well as hemipelvis flexion and extension, as these are fixed angle constructs. These can be minimally invasive if there's no need to reduce, but these are still certainly, even the MIS techniques are still a lot more invasive than percutaneous sacroiliac screws. The cons is the fact that we would limit lumbar motion, as we frequently instrument across the lumbosacral junction and to regain lost motion requires a hardware removal, which is a secondary procedure, a second anesthetic months out. There can be higher rates, there are higher rates of hardware irritation, though these can be mitigated by screw placement. And lumbopelvic fixation really limits us to the prone position and posteriorly based incisions, which frequently over-rely, degloving injuries, which are common or not uncommon with these sorts of injuries, placing patients at risk for a higher risk of adjacent hardware infection and wound healing issues. Fortunately, this is not one or the other. We can combine these techniques when there's a compelling reason to do so. In this case, lumbopelvic fixation essentially does what a neutralization plate does in a lag neutralization construct. It resists shear or rotational flexion. And so common reasons to do this are unstable sacral fractures in which we've lost our corridors, patients where our pelvic fixation is limited, our anterior fixation is sort of limited by the presence of open wounds, an open XLAP site, or obesity, or simply supplemental fixation in patients with poor bone. And with these constructs, we can allow patients to weight bear immediately. So in developing an operative plan to any patient that comes in, we need to answer these questions, these 4 questions. So is a neurologic decompression needed? And this depends on whether there's any ongoing nerve compression. The next question is how will we reduce the fracture? And in general, we start from the least invasive to most invasive. So start off with closed techniques, percutaneous techniques, and open techniques. The third question is, do we need to fuse the lumbosacral junction? And for me, this is driven by the presence of a displaced or floating L5-S1 facet. And then the last question is, well, what instrumentation are we going to use? And there are 2 big considerations here. One is the osseous corridors that are available. And when it comes to lumbopelvic fixations, whether we'll be using an open or percutaneous technique. And this decision that drives open versus percutaneous when we're going down this path is really driven by our answers to the first 3 questions. So our first case example, this is a 30-year-old Female patient with a history of a meth-induced psychosis presenting after walking into traffic. She presents with pelvic pain. There's no new numbness or weakness. We know this patient on her service because we fixed her T12 transfractures 2 months prior after the last time she had walked into traffic. On exam, fortunately, she's motor intact and her sensations intact through her bilateral and bilateral upper extremities. So these CT cuts, demonstrate a complete vertical fracture that goes, anterior to posterior. It's non-displaced. There's no transverse component on the sagittal reformats, and she does have some anterior ring involvement. So according to our classification, this would be a B3 type injury. So vertical, at the level of the frame. And so let's go back to our questions here. Is the neurologic decompression needed? No. How will we reduce the fracture? It's pretty much reduced, so closed. Do we need a lumbosacral fusion? No. How will we instrument? So in terms of our osseous corridors, she has an S1 sacroiliac corridor and an S2 transsacral corridor. And so we could do this percutaneous. So our plan for this patient is posterior iliosacral screws plus or minus anterior fixation, depending on the stability of the ring. And so this is what we did. And so with this patient, given her her social history, we wanted to, I ended up plating the anterior ring, and we can sort of debate the utility of this. But with this construct, knowing that she was, we would allow her to be weight bearing as tolerated. She has good bone stock. There are 2 solid screws in the back and robust anterior fixation. The second case is a little bit less straightforward. So a 29-year-old investment banker was hang gliding, crashed here just south of the city. It required a 1 hour for paramedics to get to him. He complained of the inability to walk after injury, bilateral hip pain, low back pain, and had numbness and weakness predominantly in the left leg. He had normal rectal tone and sensation on admission. And this is his pelvic x-ray, and it has several notable findings. I think that for me, the most striking things are his right trochanteric hip fracture with subtrochanteric extension, his left hip dislocation. So we, after reduction of his left hip, his left lower extremity weakness improved. So it was likely due to sciatic nerve tension. In terms of the pelvis, the films actually, there's nothing that stands out glaring, but what we see here is what we call a paradoxical inlet, where the anterior sacral body, we're looking down the anterior S1 body, which is not typical for an AP pelvis and is a sign of a lumbopelvic dissociation. So this is a sacral injury. So he has a U-type sacral fracture with bilateral sort of vertical limbs that you see on the axial and the coronal views. And on the sagittal films, we see that the sacrum is kyphosed roughly 40 degrees. So this is a C3 type injury. So on the second hospital day, he's taken for fixation by Dr. Shear of his right femur. And after that procedure, we attempted to see how much we can get in terms of a sacral reduction. So the patient was fully relaxed with muscle relaxants. We hyperextended him on a sacral bump. And with bilateral femoral traction, there's no change in his sacral kyphosis with closed manipulation. And so in terms of our operative treatment, going back to our questions, is a neurologic decompression needed? No. How will we reduce the fracture? So I couldn't get a reduction closed. So our plan is to do, and I was pretty certain we wouldn't be able to do it just percutaneous techniques. And so planning to do an open reduction with instrumentation of the L5 pedicles and the ilium. And then considering a possible sacral laminectomy if we need to access the fracture site. In this patient, we didn't need to fuse the lumbosacral junction because there was no L5-S1 injury. And in terms of instrumentation, the plan is iliosacral screw for provisional fixation and supplemental L5 to ilium lumbopelvic fixation. And so this is our plan. So open fracture reduction, and then lumbopelvic fixation and S1 transsacral screw. This is a typical setup for a patient with this sort of injury. And here we're doing everything we can to facilitate a fracture reduction, muscle relaxation, which unfortunately precludes neuromonitoring. We have the patient in bilateral traction, again, full relaxation, hyperextended with the use of bumps. Some people advocate for the use of cranial traction, but I typically don't do that. So despite this, we did our open approach, and despite positioning first, we still had residual sacral kyphosis at the start of the case that was similar to this pre-op CT. And so we start with our S1 chance pins down the S1 pedicles to control the proximal segment, and then place iliac chance pins to control the pelvis. With maximally trying to manipulate these and the rod bending, we still had a fair amount of sacral kyphosis. And this is sort of, the reductions here are not all too different from like reducing the distal radius. If we have a dorsally convoluted shortened distal radius, we don't just flex forward. We have to, get some length. And it's really a combination of using a combination of techniques. And getting the length here is really the most difficult part. Because you can imagine if we try to distract these two sets of pins, we essentially exacerbate the sacral kyphosis that we're trying to correct. And so we really need to sort of hinge and so because this was not successful, the next thought plan was to do a sacral laminectomy and place a cob down the fracture site, so sort of a modified Kaponji to go back to our distal radius analogy. And there you see our cob trying to shoehorn that fragment through the fracture. At the time of the sacral laminectomy, we found that he had a frankly severed S3 nerve root on the right and a complex ventral dural tear that was traumatic and unrepairable. So this is what this looks like in the wound. Here we have the T handles on the S1 pedicles. And here I have the femoral distractor and the X-fix bars, but these are not distracting. These are just, I'm using these to be able to have a fixed angle lever arm over the pelvis. And one of my mentors, Dr. Belbarba up in Seattle, from whom I learned a tremendous amount regarding these injuries, told me that, really a reduction is only achievable once we've sort of given up hope that's achievable, which is sort of the case here. But eventually with our cumulative efforts, we were able to get to where we wanted. Once we had this provisionally held, we placed an S1 transiliac transsacral screw to hold everything together so then we can exchange all of these instruments up here for this definitive fixation. We didn't do a formal fusion here, so there's no injury to the sets. And the plan is to remove the L5 screws after sacral fracture healing so that this young man can get his motion back subsequently. And here are the postoperative images. So when comparing the pre-op and post-op CT, we focus on the sacral kyphosis. But what I want to draw your attention to is on the pre-op CT, just look at the amount of lower lumbar lordosis. That's even just when the patient's supine, because of this deformity, and we sort of ameliorate that with our treatment. And there are sort of AP and lateral of our final construct. But the story's not over. Postoperative day course. So at the time of the OR, because of his dural tear, our neurosurgery colleagues placed a lumbar drain to help treat that. He was neurovascularly intact the morning of post-op day 1. A couple hours later, he was endorsing decreased perianal sensation and loss of voluntary tone. His hemovac drain had not put out, given the amount that we had expected it to put out. And so we took him to the OR for a presumed compressive hematoma, which is described in several case series here, or as well as pseudomeningeal and the like. And then subsequently, Dr. Toogood treated his left acetabular fracture dislocation. Last saw this patient 2 months ago at 6-month follow-up. He was ambulating unassisted. He's still 20 pounds under his pre-injury weight, despite being, having a normal body habits to begin with. He still has, intermittent bladder spasms that have transiently resolved with Botox. He's continent to stool at this point, but with the use of scheduled voids, his perianal sensation is still incomplete but somewhat present. And right at this point, we're awaiting a CT to evaluate for gain in anticipation of a possible hardware removal. Our third case is a 81-year-old gentleman with ankylosing spondylitis after a fall down some stairs, a possible syncope, no new numbness or weakness. He was previously treated upper Parnassus with C3 to T3 fusions for a cervical fracture and subsequent T3 to T11 for a thoracic fracture. He lives unassisted. He's neurologically intact. These are his representative images. So he has bilateral non-displaced vertical sacral fractures with ankylosis of his spine all the way above. In terms of his osseous corridors, he has no transverse S1 corridor, and his S2 is really small, measuring about 7 millimeters in diameter. And the screws that we typically use for these are 6.5 millimeters or larger. So with bilateral vertical injuries, this is a C2 type injury, and he's fused upward, and he's fused upwards from L5 up as a result of his ankylosing spondylitis, resulting in a long lever arm. So is a neurologic decompression needed in this gentleman? No. The fracture is pretty much reduced. We don't need to fuse the lumbosacral junction, as these patients reliably heal really well. And then how will we instrument? So in a patient without osseous corridors, S1 and S2 corridor that is too small for my comfort, we elected for lumbopelvic fixation because we don't need to do a reduction. Our plan is to do this percutaneously. And so, he put in percutaneous screws in the pedicles and in the ilium. And for him, because he was already fused proximally, we extended up proximally without any sacrifice in motion. In terms of his postoperative course, we allowed him to immediately weight bear postoperatively. He was transferred to a SNP post-op day 2, and when he came back to see me at 6 weeks, he was ambulating with a walker. Our fourth case is a sort of a less straightforward case. 55-year-old firefighter here in the city who fell 3 floors at work. He was hemodynamically unstable on arrival. Initially, he responded to resuscitation efforts and then stopped responding, so he was taken for an emergent X-lap. At which point they found significant retroperitoneal hematomas, palpable pelvic fractures that were pathogenic in an extraperitoneal approach. Then he was taken to CT on the way to IR. At the time of IR, his IR angio was negative for an arterial bleed. This was his AP pelvis after pelvic packing. And from the pelvis's perspective, we see that there's a widely displaced pubic symphysis consistent with an APC type pelvic ring injury. So on the axials, we see significant anterior comminution within the sacrum, along with external rotation of the right hemipelvis, consistent with that APC type injury. We see signal sort of in the fluid collection posteriorly, which sort of goes in line with this degloving injury. On the coronal injury, on the coronal slices, we see this free-floating S1 superior articular facet. And on the saddles, we have this buccal fracture here, as well as a T12 vertebral body fracture. Now, full characterization is a chance variance, but we'll focus on his sacral fracture. So his sacral injury would be a C1 type injury with a vertical pattern. You could also argue that with the buckle there, that's a lambda pattern, would be a C3. But the crux of this is that sacral is that superior articular facet. So on hospital day 2, he's moving all extremities when a sedation was weaned. He was taken back to an for a repeat X-lap and removal of packing and placement in an external fixator. So again, Dr. Morshid made this look like a pelvis again. At this point, he was not stable given his respiratory status until hospital day 12 because of his ARDS, which included operative intervention. At that point, he underwent iliosacral screw placement with the placement of 2 S1 screws and an S2 screw. So this is pretty robust fixation using all the available posterior corridors. An anterior external fixator was kept in place at the time. The next day, I planned to take him. I took him back to address his T12 injury and to wash out his Morel lesion in anticipation of potentially doing something for his lumbar spine. So in terms of his, coming at his sacrum from the spine's perspective, if we were to do something, we don't need to do a neurologic decompression because he has no evidence of nerve compression. How will we reduce the fracture? He's this is the best case scenario. He's already reduced by the pelvic surgeon. I don't have to do any work. So again, another thanks to Dr. Morshid. The third question is, do we need to fuse the lumbosacral junction? And for me, in this patient, we do. For me, this requires an open approach. And so while we can, it's definitely, we definitely perform fusions through MIS techniques in the setting of high energy trauma. For me, this is an open approach with preparation of a robust fusion bed. And had we not been pushed to fuse and we simply wanted to supplement fixation, then, given his sacral comminution, then we could, consider percutaneous L5 to S1 instrumentation, but because we're already going to open to fuse, we'll do an open lumbopelvic fixation. So that's our plan. And this is the construct that he ended up with. And so we allow him to weight bear on this construct immediately, which we otherwise wouldn't. The X-fix was taken off at the time of displacement. And again, given this sacral comminution, this would not be a fracture that most practitioners allow to weight bear if it was just posterior SI screws. So here I must say that given the heterogeneity of injury patterns, the relative infrequency of the most significant injuries, all of what we know regarding these injuries are based on small retrospective cohort studies. And so really this is a tale of 2 studies. So these are the 2 sort of seminal articles that sort of that describe the different fixation strategies that we come in. And these were sort of in the early 2000s. And so in the first study looked at, this is actually the second article looking at the same group of patients. So it was 19 patients undergoing open lumbopelvic fixation and decompression. And 83% of those with neurologic deficits had a full or partial bowel and bladder recovery. There was no loss of reduction at over a year follow-up. However, there were a significant amount of complications and sort of findings. So the first one is not really a complications, but on decompression, 74% of these patients were found to have a traumatic dural tear or nerve root avulsion as a result of their injury. Subsequently, there was hardware failure was 31%, but these were not surprising. The majority of these were in patients who had rod breakage in a setting where fusion was not done. But there are a significant number of wound healing injuries, and 42% of patients had an unplanned second surgery, the majority of which were for wound infection, seromas, or pseudo wound interstitials. The other study was, looked at 13 patients, U-type sacral fractures that were treated percutaneously. There's only one hardware failure. All fractures healed at final follow-up. 7 out of 9 with preoperative deficits had resolution without any wound infections, and 1 unplanned surgery for a hardware removal. So with this, with this data, the question is always asked, like, how can these 2 studies be coming out of the same department, at the same time with shared authors, each advocating for a different procedure? And it really comes down to the patient population. So in the first group here, the open group, the preoperative sacral kyphosis was 43 degrees, improved to 20. Whereas on in the percutaneous groups, these are people who really we accepted an in situ reduction for the most part. In terms of our displaced, C3 lumbopelvic dissociations, let's delve into the sort of the long-term clinical outcomes. So again, we mentioned our postoperative complication rate, roughly sort of 30%, and this is a combination of compromised soft tissues, a poor soft tissue envelope to begin with in that area. Patients are frequently in bed, they're prone to decubitus ulcers. There's postoperative cachexia may lead to late symptomatic hardware, similar to our second patient who had, still had a 20-pound weight loss despite being 6 months out. And this really highlights the importance of recessed screws tucked underneath the fascia. So whether we do this percutaneous or open, it's imperative to make sure that these tulips are underneath the fascia to minimize any hardware prominence. Looking at sort of more of the clinical outcomes, what we do know from the small sort of, this is sort of the next couple slides are going to summarize about like 7 studies. The risk of permanent neurologic injury relates to the initial fracture displacement and translation, as well as the presence of sacral nerve root discontinuity. Several outcome scores have been looked at. The German multi-center pelvic outcome score has been found to relate to residual kyphosis and translation. And several other studies have looked at EQ60, SFMA, POS. In terms of the studies that have looked at SF36, the patients' scores are significantly lower than the general population, specifically in the domains of vitality, role, emotional, and mental health. And these are strongly related to residual neurologic deficits, namely bowel and bladder and sexual function. The majority of these patients, not surprisingly, are able to ambulate without devices, as these are lower sacral injuries in general, below our S1 nerve root. But despite that, 30 to 40% will have a change in profession or beyond disability a year out. And so in terms of like studies that compare lumbopelvic fixation to iliosacral screws, I mean, this is the only study I can find, and I'm still on the hunt for more. But this was, just to give you sort of a sense of, sort of the small scale of these studies. This was 16 patients over a 6-year patients, definitely an underpowered study. They did not identify any differences in ICU requirements or length of stays, even though it wasn't statistically significant. The lumbopelvic patients were significantly younger. The complications, it's hard to make, to make, sweeping generalizations based on the numbers here. But what they did find is lumbopelvic fixation patients were more likely to be discharged home as compared to SNF. They made the argument that this was due to weight bearing, although, the age is probably the driver in this finding. And so this is a slide that I've borrowed from one of Dr. Bourbon's talks, and something we've all heard before, that the presence of variance in practice patterns is clear evidence of the absence of an evidence-based approach. And this sort of absence really in this particular patient population is driven by just the relatively low frequencies and the variability in fractures. So, and so consequently, the treatment of sacral fractures is ideally, conducted. So in terms of our future direction, so what I hope to do here, for us to do here at UCSF in the next couple of years is really to evaluate the long-term impact of residual sacral kyphosis in these injuries, to evaluate the pre and post reduction sacral kyphosis with different techniques and see what reduction we can expect with different techniques. And then to evaluate the long-term outcomes for our Isler type injuries and the need for reoperation from arthropathy. And then sort of a clinical question that would probably be best served with a prospective study is looking at weight bearing status and discharge disposition based on whether we supplement or do triangular osteosynthesis, especially in our vertical shear fractures, especially if we're able to allow these patients to weight bear earlier. And so treating these sacral injuries is ideally conducted through a symbiotic relationship between the pelvic surgeons, the spine surgeons. And the greatest omission from this talk is really the importance of our physiatry and our rehab medicine colleagues, especially in patients with these sacral nerve roots. All our treatment is really sort of upfront in the beginning of their care, but the long-term consequences and what really affects their long-term outcomes is really the resolution and addressing the neurologic injuries that patients have because of these injuries. So again, these represent a wide spectrum of injuries. The development of sort of a comprehensive classification scheme is going to make doing research and and hopefully our decision making easier. And again, as with everything, the goals are reduce takes what's to stabilize what's unstable and to decompress anything that's compressed. And again, of course, would like to thank you for the opportunity to speak here. And specifically would like to thank Dr. McLeod and the OTI who provided me with probably the densest, most educational year of my training and fellowship here, as well as really taking on this vision for the future of spine trauma care as we expand these efforts in the Bay Area. The folks who trained me up in Seattle, who I'm incredibly indebted to, and then the entire UCSF spine team, including the neurosurgeons here at at San Francisco General, who've all been colleagues in the truest sense of the word. And then Dr. Lotes, who from whom I learned quite a bit in my year, and Dr. Diab, who was my first introduction to orthopedics when I was a med student a couple of years ago, and really for his continued mentorship throughout all these years. So again, thank you all.
Great, thanks, Ashraf. And those were complex cases and definitely interesting approaches and a lot of good information. And we could open it up for any discussion. Feel free to unmute yourself and ask away.
Ash, I'll start. Thank you very much for that presentation. It's a complicated problem, and I think you clarified the issues really well and outlined what made it easy to conceptualize a lot of the anatomy and the problems. And I think you also outlined the overall issue, which is that so many of these injuries are so different and there aren't too many of them. So trying to study them becomes quite difficult. And so I actually had two questions for you. How would you approach something like that with these injuries being so different and so infrequent? How are you going to do better clinical outcome studies on them? And then secondly, another area that is continually controversial is sort of recovery following decompression, whether you decompress affected nerves or you leave them alone. And I was wondering if you could comment on that as well.
And so clearly no single center has the volume in order to really so these efforts are going to have to be multi-centers. And so I think our first step is to figure out what the variation in practice is now, who's tackling these injuries across the country, whether it's the spine surgeons or the pelvic surgeons, and what sort of what the current practice is. And then subsequently, and then people have been treating these really a lot more so over the last 20 years. And so it's pretty simple to do retrospective studies for some of the questions that we raised in terms of, really the outcomes for, our Isler type patterns. But these would have to be combined efforts, much akin to the work that's been done for our understanding of, femoral neck fractures in the young. So it's sort of similar constraints. And in terms of, the nerve decompression, I mean, the question, for me, like the bigger question is like with these severed nerve roots, these are all like peripheral nerve roots. Like, is there a role for like, doing, a repair? I mean, these nerve roots, if they're only going to the bowel and bladder, the distance that they have to travel is not as, as far as say, if they have to go down to the toes for, another injury. So I think, the nerve root questions on whether, so what we do know in terms of decompression or not, people do tend to improve afterwards, but it's really hard to say whether this is just the natural history of these injuries or whether it's because of the decompression. But it's really hard to see someone with sort of an obliterated sacral canal and decide not to do anything.
Ash, that was a terrific overview, a really complex topic and truly a disabling set of injuries. Clearly, there are multiple disciplines involved. I thought it was interesting your attempt to compare transiliac transsacral screws to lumbar pelvic fixation. And truly, these really are different injury patterns in general. That we're generally dealing with a much more displaced fracture, higher grade. Both those pictures were out of Harborview, but they actually weren't shared authors, were they? They were more trauma.
Yeah. So the open one. So on their earlier study, Dr. Nork was, I believe, on one of their earlier studies. But yeah, the two studies, the names were different, but in the preceding studies, it was the same group of folks.
Yeah. So what I was getting at is that there tends to be much more a differentiation between pelvic surgeons are doing more of the transiliac transsacral, whereas you're going to engage somebody who's more spine trained. And this is where you've got such an advantage of having training in both. But to tell us a little bit about how you work as an interdisciplinary team, because again, you've got your trauma surgeons, your pelvic surgeons, you got your spine surgeons, and in many cases, the neurosurgeons might be involved in some of these cases as well.
Yeah.
So you work that out as an interdisciplinary team in real time.
Yeah, and so it's all really guided by what the patient needs, and so I think the two main sort of groups of patients that we see are those with sort of an initial, like, who present with either hemodynamic instability or present with nerve deficits, and depending on what the most pressing need is, that usually guides like who's going to do what first. In terms of these displaced sacral fractures, it's really hard to, if it's in combination with a pelvic ring, it's hard to control the pelvic ring from posteriorly. And so in those scenarios, having the pelvic surgeons reduce the ring is of great importance, and put in their sacroiliac screws. We looked at those corridors for those sacroiliac screws. So those screws are confined into, there's a small space for those screws to fit in. Whereas our iliosacral screws, if we're eventually need to do that, it's easy to shoot around those screws. And so for patients with sort of these pelvic ring injuries, what we typically do in my year of training up north is, so patients would be reduced, and then if there was, if a need arose if the decision was already to do lumbosacral fixation, or if there was they felt that the purchase was not great, then we would just simply, sort of almost as like an intraoperative consult. Usually we would talk to the patient beforehand. I'll just, flip them prone with the pelvis already reduced and do our percutaneous fixation if it's more of a supplemental fixation. Again, these are the two things here that are sort of difficult to sort of divide is, screws and lumbopelvic fixation, those are techniques, and, and we can apply any of these techniques to any of these different injury patterns. And the two big categories of injury patterns that we see are vertical fractures of the pelvis and these bad lumbosacrals. And so it's really a discussion, between the two surgeons and beforehand, and it sort of guides treatment. So.
Any other thoughts or comments?
Yeah, I just have a quick one, Ashraf. Dr. Vale here. Really appreciate all your contributions. Great lecture and overview, even for us non-spine surgeons. One of the comments you made in passing, I think, was referring to taking some of the hardware out to allow motion. And this is a unique situation since, as you mentioned, you're not fusing, you're reconstructing, and you're trying to maintain motion. And so can you just elaborate on that a little bit? Some of those constructs that you showed, whether it's iliosacral or transsacral. Which parts of that hardware do you think are appropriate to remove at a later date?
So if we just think of like the our sacral U-type fractures, where that we've stabilized with screws into L5 and down into the pelvis. If the fracture that fracture is entirely within the sacrum, so if that we're just using our screws in the spine and the pelvis just to temporarily hold everything together until the bone heals. And so we, in order to get enough points of fixation, we have to go above the L5 S1 disc, which normally has a fair amount of motion. And so we lock patients up temporarily, but if their fractures heal, then we no longer need the hardware in place. And so at that point, in order in patients, it makes, if we just simply remove the L5 screws and the rods, and frequently we will remove everything, then they'll regain that motion after their fracture is healed. When it comes to iliosacral screws, and this is sort of going, to a different topic. Whenever we put iliosacral screws for the, we're crossing a joint where there's, small, there's some motion, albeit small. And, people have described some, residual sacroiliac, some patients go on to develop residual sacroiliac pain. That can be, and that's we're thought that because we have fixation across a joint that's meant to move, and we similarly do the same technique. So if the sacral fracture, if it was used to treat a sacral fracture, and they have, this pain that's thought to be because of this hardware that's crossing the joint that otherwise has motion, then we can take that hardware out.
Great. It is just about 8:30. Any other final thoughts? And if not, Ashraf, thanks again so much for presenting this morning, and great overview, and a lot of really good information. And we will see you all in 2 weeks for our next Grand Rounds.
Thanks.
Great job, Ashraf. Well done.